Hi guys, today we'll be talking about the management of Holstein Lewis fractures. So, what is a Holstein Lewis fracture? A Holstein Lewis fracture is nothing but a spiral fracture of the distal one-third of the humeral shaft with accompanied radial nerve palsy due to the entrapment of the radial nerve at the fracture site. So, as you can see, when the radial nerve passes through the spiral groove, it's in the posterior compartment, it enters the anterior compartment by piercing the lateral intermuscular septum and comes anteriorly and runs over the lateral epicondyle, and then it divides into your pin and your superficial radial nerve and all that. As you can see clearly in the distal one-third humeral shaft, when the radial nerve comes in the anterior compartment due to displacement of the fragments, this is how the radial nerve becomes entrapped, and this is the reason why this particular spiral fracture pattern leads to your radial nerve injury. So, what we should remember mainly is that most of these associated radial nerve injuries in the Holstein Lewis fracture are either neuropraxias or axonotemesis and recover spontaneously in 90% of cases. So, if we come through a brief algorithm of how we treat these fractures, suppose it's a closed fracture. As we already said, it most likely is a neuropraxia or an axonotemesis, and the patient is poor, he can't afford surgery, and the fracture has an acceptable criteria for functional brace, reasonable resistance to telescopy, the fracture site is painless. We put a U slab first, wait for the fracture site to become painless, and once it's painless, then we can do all this. What we do is we observe for 3 to 6 months. If there's no recovery, then we do a nerve exploration. Usually it's 3 to 4 months, but some books mention 6 months as well. And then once we do the nerve exploration, we do a neurolysis, or if the nerve is toned, then we do a neurography. Then we do brace plus rehabilitation. What they mean by brace plus rehabilitation is basically put a cock-up splint, make sure you give muscle stimulation so that the muscles don't degenerate or atrophy too much, and also we maintain the range of motion of the upper limb, including the elbow, shoulder, and especially the wrist and the fingers. As we know, with radial nerve palsy leads to wrist and finger drop. And suppose even after doing that, there's still suboptimal / no recovery for an additional 3 to 6 months even after your nerve repair, then we do a tendon transfer. In the tendon transfer, we do something called a modified Jones transfer, where we use the pronator teres to the extensor carpi radialis brevis, which helps with wrist extension, FCU to the EDL, extensor digitorum communis, which is for finger extension, and the palmaris longus to the EPL, which is the extensor pollicis longus, which is for your thumb extension. So the main deficits were wrist drop, finger drop, and thumb drop, and we restored all these by this transfer called the modified Jones transfer. Suppose if it is a fracture pattern that needs ORIF and the patient is affordable for surgery. What I mean by this is that most of the Holstein Lewis fractures need surgery, and when we do the plating, usually we can use a regular 4.5 mm limited contact dynamic compression plate. But suppose the fracture is slightly more distal and we are not able to fit the plate, we usually end up using an extra articular plate. I'll show you what that is in the upcoming slide. And during the nerve exploration, if the nerve is intact, we just plate it. We don't do anything to the nerve, and we just wait and watch for a period of 6 months. Even after 6 months, again, if there's suboptimal recovery, then we will have to do a tendon transfer. Suppose the nerve is cut during the exploration, then we have to do a primary repair, where we just do an epineurography or a perineurography, where we just repair the ends of the epineurium to each other, or perineurography is a more refined repair, where we repair each of the perineurium to each other one by one. So mostly what is done is an epineurography. Then a few more conditions. Suppose a palsy develops. Suppose the patient comes to the fracture, he had no palsy, and during your manipulation where you try to reduce the fracture in the ER, he develops a neurological deficit. Or if the patient initially presented to you only a finger drop, but later he presents with a wrist drop as well, which indicates that the neurological symptoms are progressive, then we have to do a nerve exploration with ORIF plus plating immediately. These are the two conditions where immediate exploration is mandatory. Suppose it's an open fracture where there's a contaminated wound, and what we do is we have to find the nerve ends, we have to debride them, and we have to tag them. And we put an X-fix to maintain the stability. And then once the wound status is healthier, then we do RF plating plus the nerve repair. However, if it's a clean cut lacerated wound with an associated fracture, we can do a primary nerve repair plus plating. And as you can see, we wait and watch in all these situations for a period of 6 months after your nerve exploration / nerve repair or whatever you do. And then if there's still suboptimal recovery, then we do a modified Jones transfer, which is a tendon transfer. What we should remember is that during all this period of rehab, we should do electrical stimulation of the muscles. We should maintain the ROM of the muscles. We should make sure the joints are supple, and also we should use a cock-up splint, either a dynamic or a static one, depending on the situation. So yeah, this was a Holstein Lewis fracture, which was plated with as you can see, it's an extra articular plate, because the fracture was quite distal and we couldn't fit a 4.5 mm LCDCP here, so we had to use an extra articular plate. And then after this, it was a closed fracture, so we just wait for a period of 3 to 6 months. If the nerve recovers well and good, usually neuropraxia recovers in about 6 to 8 weeks, whereas axonotemesis may not recover for up to usually recovers by a period of 6 to 18 months. So it's a wide duration. So what's important to look for is signs of nerve recovery. If there's a motor march or a progressive Tinel sign, these things indicate that the nerve is recovering and there's no need for intervention. However, if there's a static Tinel sign, there's no motor march, there's no signs of nerve recovery at all, at a period of 3 to 6 months, based on case to case basis, we have to do a nerve exploration. Okay, that'll be it. Thank you.